sure. I think maybe it's going to the left. And then next is Eisenmenger syndrome. Eisenmenger syndrome will be discussed later. Next. So this is investigation. First, the lab study is not specific just because of the person may have certain symptom. So they may go food blood count, blood time, screen, metabolic profile, and chemistry panel, and coagulation study, PT and APTT. This is because of some Eisenmenger syndrome may also cause coagulation. Next. Imaging study. So imaging study, we can do chest radiogram. So chest radiogram may show cardiomegaly can be seen in clinical significant left to right shunt. So it will cause cardiomegaly. And then pulmonary artery is prominent. Vascular marking increase in the lung field. Chest X-ray. Next is transthoracic echo. It provides direct non-invasive visualization of the most type of SD, able to evaluate right atrium, right ventricle, pulmonary artery, and other associated abnormality. Doppler echo. As you know, Doppler it measures blood flow. So allows evaluation of flow of the across septal defect and can give precise information regarding the selection of appropriate occluder device. Next. MRI, it may use to identify the position of the ASD. And then ECG. So ECG, it may show right bundle branch block. So if you see the ECG part, you may see the apa QRS complex. It become like M shape. QRS complex. So that M shape is refer to may refer to right bundle branch block, because the right ventricle become bigger, so lack of the blood supply, and then it will cause ischemic to the lung, to the right wall of the ventricle, and it may cause bundle branch block. The electric impulse is not enough going to that part. Next. So this is a management of ASD. So if ASD is small, no intervention needed because it may close later in life. And then it is if this is medium or large size, that is we can undergo transcatheter closure. So transcatheter closure basically it will there is like umbrella shape structure of the it will go to that hole, and then it will close that hole. And this is done by insert the catheter from the from the left I think left or right iliac, and then into the abdominal aorta, and then go to the ASD. And then surgical closure, this one just the surgeon will open the thoracic wall and then just patch the some kind of, like you see patches, they patch into that wall, so there's no leaking. Next. So this is a complication of the ASD. So atrial arrhythmia, pulmonary hypertension, and Eisenmenger syndrome. So this is the mechanism of Eisenmenger syndrome. Left to right shunt, it will cause high pulmonary blood flow, just like explained just now. And then pulmonary vessel remodeling, increase in muscle and so on because work a lot. And then layer of smooth muscle increase pulmonary vascular resistance. So pulmonary vascular resistance become increase, and then increase pulmonary pressure and pulmonary hypertension. And then right to left. So this is what you call as a paradoxical shunt. So right, and then because of the hypertension, it will cause right to become high blood and then go to the left. So terbalik. And then patient may get cyanotic because the blood is mixing between oxygenated and deoxygenated blood. And then because Eisenmenger syndrome. And then cyanosis, patient may got cyanosis because of that right to left shunt. Usual presentation is breathlessness, but because of that paradoxical shunt, it will cause um, it will cause other it will cause cyanosis, which is refer to right to left shunt presentation. And then paradoxical embolism. Paradoxical embolism refer to embolism that embolism usually, as you know, is from vein, right? So because of the flow, it will go to the artery instead of vein. So when it go to the it go to the internal carotid artery, it will go to the brain, constrict the blood vessel of the brain, and then cause stroke to happen. So this treatment is used to treat the complication. I think that's all. Is it? That's all.
Any questions? Any question? Go to the first slide. Any questions? Any question from the members? The next slide. Siapa yang present tadi Mustaqim ah?
Yes.
Okay, next. Okay. Okay, this one okay. Cuma nak highlighted ostium primum is different entity. Ostium primum ataupun ASD primum, nama lain dia, the other name for this defects is the incomplete AVSD, atrioventricular septal defect. Okay, so it's different entity actually. It's the problem with the it's involved the endocardial cushion area. So they may involve the mitral or tricuspid valve. Okay, next slide. Okay, ni yang ni. You banyak goreng Mustaqim. Hangus you goreng. Okay. Usually asymptomatic, yes. This the symptom apa ni? Symptom apa ni Mustaqim?
Shortness of breath, fatigue.
Yelah, I tahu lah. You tak payah baca, I baca. In general, what the symptom of what condition ni? Shortness of breath, fatigue, failure to thrive. Members, group members pun boleh jawab. This is the symptoms of heart failure in children. Shortness of breath, fatigue, failure to thrive. Okay, it's nothing to do. You punya goreng tu hangus. It's nothing to do. Sebab apa pula less oxygen pula? ASD is acyanotic. It's not sinus. There is no problem dengan oxygen. Walaupun dia left to right shunt, bukan maksud bila left to right shunt, so left side tak dapat oxygen. Kurang oxygen. That's the way you explain. The shortness of breath bukan dia tak dapat oxygen. Shortness of breath is because heart failure. Because you did mention just now, patient shortness of breath because not enough oxygen. So when left to right shunt, so lack of oxygen. There's nothing to do with oxygen. You check saturation and patient with acyanotic heart saturation more than 95%. Boleh dapat 100% pun. You punya reference ni daripada mana you ambil ni? Because the wrong concept and your understanding is wrong, your concept is wrong. I nak tahu you punya reference ni kat mana you ambil ni.
I'm sorry, shortness of breath is due to
tak ada, you jawab soalan where you take the reference ni. Where you take the reference. Reference for the slide ni daripada mana? Buku ke artikel ke apa? Or you ambil, you copy and paste daripada previous group. Not valid, is wrong. Yang tak boleh dibuat sebagai reference lah. That's my point.
Shortness of breath tu saya silap sebab tapi saya tengok YouTube sebab
semua you silap. Bukan shortness of breath je silap. You punya your principle silap. Bukan you jugalah. Maksud your group members, the whole group ni, yang group 3 ni semua silap. You punya concept is wrong. Okay, bukan you seorang lah, because you adalah representative of your group. So the group member ni semua salah. Dia punya understanding. You punya statement ke betul, dia boleh dapat di symptom, but the explanation why the symptom develop. Go to the next slide. Oh, ini tak cakap lagi. Okay, previous slide balik. Yang ni nanti after this. Okay, ni semua tu. Dia tak ada nothing to do with the lack of oxygen. Okay, this is the failure symptoms. Kalau patient develop heart failure, which is rare in ASD, dan patient boleh presented with this. This is the symptom of the shock ni because of the, bila heart failure apa berlaku is the not adequate cardiac output. Tak cukup cardiac output dan berlakulah apa? Tissue not enough. Tak boleh nak fulfill the metabolic demands of the tissue. So this symptom develop. Recurrent infections, yang tu betul lah. Okay, because of the fluid, lung, flooded of the lung, semua tu dia boleh dapat ni. Okay. But it's not because failure to thrive tadi pun you kata because tak dapat oksigen apa. It's nothing to do because tak dapat oksigen. Saturation is more than 95%. Failure to thrive because heart failure. Bila heart failure maksudnya all the calorie of the patient semua tu being used by the heart. Because of patient shortness of breath, patient dyspnea, tachypnea, all the respiratory effort. So the calorie tu habis kat situ je. Patient tak boleh nak grow. Failure to thrive is symptoms of heart failure. In this case, it's not because there's not enough oxygen. Because dia cyanotic heart. Dia bukan cyanotic. It's cyanotic patient, yes. It may impact because of the low oxygenation. But not in the cyanotic heart. Not in the acyanotic heart. Acyanotic heart, there is no issue of oxygen. This because failure symptoms. Okay. You dapat heart failure, you tak ada ASD pun, you dapat heart failure for whatever reason. For example, myocarditis, cardiomyopathy, you will have this symptom also. Okay. So benda tu yang you kena betulkan dan konsep tu you kena betulkan lah. You tu bukan you seorang lah, everybody. Okay. Because that's why it's important to understand. Bukan ada sambil. Kalau nak copy pun you kena understand. I tahu banyak slide ni, I dah tengok dah banyak kali, I tengok the same slide. You have the collections of the previous slide. But it's important bila buat slide tu you understand apa yang tu kena baca sikit. Bukan baca point saja. Bukan guna common sense, logic. Kat sini tak boleh guna logic. Logic without knowledge is failure. Okay. So issue dengan what? Fixed splitting of second heart sound. I think you punya because late closure of the pulmonary valve because you cakap tadi fluid lung overload. So dia lambat. Delay closure of the pulmonary valve is not because of the fluid overload. It's nothing to do with fluid overload. Go to the next slide. Kat sini nak tengok apa dia tulis. Next slide. White splitting second heart sound. Physiologically, aortic valve close slightly before pulmonary valve during inspiration. Overload of right ventricles. Dia betul tulis kat sini. It's not overload of the lung. Overload of the right ventricles. Causing delay closure.
Right ventricle.
Increase venous return.
Saya tak
sebut
cakap
lung tadi. You cakap kat lung tadi. I'm listening. Because you punya konsep salah, Mustaqim.
Tapi saya rasa saya cakap right ventricle.
You rasa lah masalah dia. Masalahnya, I tak tahu dia ada what are you listening? Because I focus on this because from the initial slide already the wrong concept. Kalau betul, it's okay. But kalau I tak silap, you mentioned that there's because lung overload, so lambat delay closure of the pulmonary valve. I ada buat catatan nota kat sini, Mustaqim. I bukan nak argue dengan you, but you should understand that. Okay. You mentioned the fluid overload in the lung, late closure of the pulmonary valve. I ada buat catatan. Kat sini is correctly written. It's the overload of the right ventricles. It's because of the increased venous return to the right side. Orang normal pun boleh dapat splitting second heart sound, physiological splitting during inspiration. But in PDA, okay, in ASD dia punya karakteristik, dia punya term yang membezakan dengan normal people is the fixed splitting of the second heart sound. Because dia both inspiration and expiration, dia ada overload of the right ventricle. During inspiration is from the venous return, right side venous return during expiration from the left through the ASD. So both during inspiration and expiration there is increased venous return to the right side. Increase delay closure of the pulmonary valve. That's why they fixed splitting. So the term the fixed splitting, widely fixed splitting second heart sound. Kalau split saja, normal people pun boleh dapat splitting second heart sound. Okay. So you mention just now pasal ejection systolic murmur. You sebut just turbulence. Turbulence kat mana tu? You cakap turbulence flow tapi you tak further ni. Turbulence flow kat mana?
Ventricle.
Turbulent flow di ventricle. So it's wrong. Okay. Kenapa nak what the other lesions? Siapa lagi you punya group members? Okay, group member lain tolong jawab juga. Because I'm not attacking you Mustaqim. Because you the presenter lah. Boleh identify yourself. Boleh unmute the microphone of the other group members. Siapa dah group member you Mustaqim?
Doktor.
Ya. Rozaini.
The systolic ejection murmur.
Apa lagi yang bagi ejection systolic murmur?
It can also be because of the regurgitation of the
Sorry?
aortic valve.
Regurgitation.
Aortic valve.
Regurgitation of aortic regurgitation is ejection systolic murmur.
Sorry, Doctor. No. Stenosis, Doctor. Stenosis and aortic stenosis.
Bacalah dulu. I tahu the notes in front of you. Bacalah dulu sebelum jawab. So, ejection aortic stenosis dan?
Yes, Doctor.
Aortic stenosis dan?
And mitral stenosis, pulmonary stenosis, aortic stenosis.
Aortic stenosis and?
Pulmonary stenosis, pulmonary.
Pulmonary stenosis. Okay, cuba belajar pause and tengok dulu betul-betul. Okay, ni main sebut semua valve you sebut, mitral pun sebut. This aortic stenosis and pulmonary stenosis. So it's similar to the pulmonary stenosis punya murmur. Okay, so in ASD, the murmur tu is not because of left to right shunt through the ASD. It's not through the defect. It's the turbulence flow across the pulmonary valve because increased blood flow through the pulmonary valve. Sebab tu murmur dia sama je. It's not the turbulent blood flow in the right ventricle. Okay. Even dalam kat sini pun tulis ni dalam nota you ni dalam kotak ni kalau you baca carefully, soft systolic ejection murmur due to increased blood flow across the pulmonary valve. So dia mimic macam pulmonary stenosis, what we call the relative pulmonary stenosis. Anatomically is normal size but because increased volume, so dia behave macam pulmonary stenosis. Okay. So your notes is correctly written. Your understanding is wrong. Mid-diastolic murmur is because of increased blood volume through the tricuspid valve. So dia jadi macam tricuspid stenosis. Sebab tu dapat mid-diastolic murmur. Relative tricuspid stenosis. Okay, it's not easy to appreciate but theoretically you must understand the theory first. Okay, then, okay, next slide. Next slide, please. Okay, next slide. Okay, reversal of the shunt maksudnya, okay, you tak sure tadi, reversal of shunt, mereka biasa, this self-explanatory, okay. ASD is left to right shunt, so bila sebut reversal shunt, maksudnya, dia sekarang jadi right to left shunt. Because pulmonary hypertension, severe pulmonary hypertension. And dia punya end, dia punya tu Eisenmenger syndrome is the end stage of the pulmonary hypertension. Pulmonary hypertension ni dia banyak stage. Peringkat awal bila ada 6 stage of pulmonary hypertension, peringkat awal tu reversal, tapi after sampai satu certain degree tu is irreversible already. So masa ni akan berlaku reversal of the shunt. Okay. So right pressure lagi tinggi pada left pressure, so now right to left shunt. So end result dia dah kena dapat Eisenmenger syndrome is the irreversible stage already. So that maksudnya macam tu. Sebab bila benda ni berlaku? From your reading, bila benda ni berlaku? Is it berlaku masa umur first decade, second decade, third decade, fourth decade? Bila? Group 3. Siapa lagi? Ruzaini dah jawab, siapa lagi? Dia patutnya ada 6 orang kan? 4 orang lagi siapa? Ha? 4 orang lagi siapa? That's why yang suruh buat group discussion. Dia bukan just copy paste and then you present but you don't understand the thing. Semua tak nak ngaku dah. Rozaini dah jawab, Mustaqim dah present. Siapa lagi? 4 orang lagi?
Saya doktor.
Siapa saya?
Jazlin, sorry.
Jazlin. Yes, Jazlin. Bila pulmonary hypertension ni berlaku?
Is it when patient become adult?
Adult tu bila? Adult ni kalau ikut WHO 18 years and above dah adult already lah. So bila? Can be more specific.
I'm not sure about that.
Tak bagi tak je. Tak sure, okay. Tak sure mengaku senang. Saya boleh cakap. You can teach. Orang lain tahu tak? Anybody tahu? Okay. So benda ni sepatutnya dia ada tu. Kalau you baca dia punya literature, dia ada mention. Okay. Unfortunately dalam slide yang ambil ni dia tak mention. Dia tahu echo one of the modalities. I don't expect you all tahu pasal how to interpret echo is very specific. It's a specialized area. Okay, next. Same as MRI. ECG, this is the characteristic of ECG, right bundle branch block. Okay. ECG of ASD is right bundle branch block. You expect that. Typical ECG of ASD. Okay, next. Okay. Yang ni satu lagi. If you don't understand, you jangan goreng unless you baca. Okay? You cakap masuk melalui abdominal aorta pergi SD. Kita tak buat macam tu. This one all through the vein. You daripada femoral vein, IVC, you masuk RA, and then you close the ASD. Okay? Ni. Daripada sini ni. IVC, daripada femoral vein, abdominal IVC masuk RA, you cross RA into the left atrium. Okay, you buka device ni, you buka the device and then I boleh ni tak, ya, you boleh nampak. Okay, so allow me to untuk anode ni. Okay, you masuk daripada IVC, you cross the right ASD kat sini, you cross the septum, pergi ke left atrium, you open up the device and then you tarik and then you open up the another disc, you close. You tak boleh pergi from the aorta, because aorta you nak pergi macam mana ni? Aorta dia akan masuk left ventricle dulu. Left ventricle you nak naik left atrium ni bukannya senang. Through ni. Okay. So kalau you tak sure, it's better you just briefly cakap and ask. Sebab ni yang ni you cakap Mustaqim, cakap abdominal aorta. I don't expect you tahu detail pun sebenarnya. Maksudnya because this is the very specialized area. Maksudnya cardiologist yang buat benda-benda macam ni. Even the general doctor also not familiar with this procedure. So kalau you tak familiar, you maksudnya cakap briefly saja and you can ask us afterwards. Okay. Maksudnya dia kena, maksudnya you must know the limit apa. It's better macam your friend cakap dia tak tahu. So, okay, tak tahu sajalah. Walaupun nak expect, you sepatutnya baca sikit benda macam tu. Okay, next slide. Next slide. Okay, ni satu lagi isu. Okay, nak contoh sikit the paradoxical embolization. Sebab apa kita panggil paradoxical embolization? Dia punya explanation tu okay but it's not accurate. Thrombus boleh berlaku sebelah kanan kiri vein biasanya but itu boleh je berlaku sebelah kiri. Why paradoxical embolization? Because biasanya is left to right shunt. The pressure is higher on the left atrium compared dengan right atrium. Okay. Kalau this the valve. Okay, ASD kat sini. Septum. Left atrium is slightly higher than right atrium. Sebab tu dia berlaku left to right shunt. So dalam paradoxical embolization, it's a reversal of the flow. Because biasanya thrombus yang ada on the right side go to the lung. Lung is sebagai filter. So bila ada lubang kat sini, contohnya tiba-tiba ada thrombus kat sini, ada thrombus kat sini, at the same time ada certain occasion in which the pressure on the right side overcome the pressure on the left side. What condition? Contohnya you coughing, you sneezing, you straining, constipation contohnya. Unfortunately masa tu ada thrombus kat sini, so masa you batuk tu, suddenly the right side punya pressure increase, overcome the left side, so dia akan jump into the left side. Okay, so very unfortunate, macam yang Mustaqim cakap tadi, they go to the carotid artery, go to the brain. Okay, so dapat stroke. So that what we call the paradoxical embolization. Okay. It's not common, tapi it can happen dalam case of ASD or PFO. Even PFO pun boleh berlaku macam tu juga. Okay, ada soalan? I think that's the end of you punya ni kan? Ada soalan? Kalau tak ada, we go to the next group on VSD.
Good afternoon to Dr. Rizal.
Yes, cuma I think nanti bila part investigation tu, you just briefly, you tak payah elaborate panjang-panjang sangat. Just briefly outline saja.
So my group will be presenting about the ventricular septal defect. Next slide. So this is the presentation outline. We are going to talk about the definition and risk factor of ventricular septal defect, the type and classification, the pathophysiology, the clinical features, the diagnosis, and also the management. Next slide. The definition of the ventricular septal defect is the presence of the defect in the septum that divide the left ventricle and also the right ventricle, result in the communication between the ventricular cavities. This is the most common type of the congenital heart defect, account for 25% of the total congenital heart defect. It will allow the blood to pass from the left ventricle to the right ventricle. For the risk factor, it is caused by the genetic factor and the maternal factor. Under the genetic factor, we have family history of septal defect, genetic disorders such as the Down syndrome, DiGeorge syndrome, Turner syndrome, maybe some Patau syndrome or the Edwards syndrome. For the maternal factor, we have maternal alcohol consumption during the pregnancy, untreated heart issues such as diabetes, phenylketonuria, infections, and also using certain medications such as lithium and phenytoin. Next slide. The classification is actually based on the location. The first subgroup is the membranous ventricular septal defect. This is the most common type in the ventricular septal defect. It is due to the defect at the membranous septum. The location is just near to the tricuspid valve, and it is most commonly operated on since most membranous ventricular septal defect do not usually close spontaneously. The second subtype is the muscular ventricular septal defect. It occurs at the muscular portion of the ventricular septum at the lower part. And it can be multiple and result in the Swiss cheese pattern. And the third subtype is the infundibular or supracrystal ventricular septal defect. It is located just underneath the pulmonary valve, as shown in the picture. Next slide. For the clinical features, it actually depends on the size of the defect. If the ventricular septal defect is small, which is less than 3 millimeter, the patient can be asymptomatic. And on physical examination, on auscultation, we can hear the loud pansystolic murmur at the lower left sternal edge. The loud murmur implies the smaller defect. So why we can hear the loud murmur is due to the small opening. Therefore, there will be turbulent blood flow towards the right ventricle. And the patient can also have quiet pulmonary second sound. For the large ventricular septal defect, the symptoms is present with the heart failure, such as breathlessness and also failure to thrive after 1 week old. And the patient can also have recurrent chest infection due to the pulmonary congestion, because a large amount of the blood will be flow into the pulmonary vasculature when there is large defect. For the physical sign, the patient can have tachypnea, tachycardia, and also enlarged liver from the heart failure. And the patient can also have soft pansystolic murmur or no murmur, and this implies for the large defect. And also the patient can also have apical mid-diastolic murmur, which is due to the increased blood flow return from the pulmonary vasculature into the left side of the heart, and large amount of the blood will be flow through the mitral valve. This condition is known as the relative mitral stenosis. Next slide. So this slide shows the pathophysiology of the condition. When there is a defect at the ventricle, due to the higher pressure at the left ventricle, it will cause the blood to flow from the left side to the right side and result in the left to the right shunt and increase the pulmonary blood flow. Due to the pulmonary congestion, this will cause the injury to the pulmonary vasculature and result in the endothelial dysfunction and pulmonary vascular remodeling. The pulmonary vessel will build up more smooth muscle and result in the increase in pulmonary vascular resistance. When the ratio between the pulmonary vascular resistance and also the systemic vascular resistance become 1:1, this will result in the inverted shunt from the right to the left and result in the Eisenmenger syndrome, and the patient can be presented with cyanosis. Next. And this is the slide that we obtained from the Calgary Guide, the pathophysiology. I think you can refer to it later on. Next slide. For the investigation, the first is that we are going to do the imaging too. On the chest X-ray, if the ventricular septal defect is small and we cannot find any significant finding. If the ventricular septal defect is large, we can find the sign of the cardiomegaly. For the ECG, the ECG will suggest the finding of the left ventricular hypertrophy and also right ventricular hypertrophy, such as the left axis deviation or right axis deviation. For the transthoracic echocardiography, it provides the diagnostic confirmation with detailed characteristics of the size, the type, the number, and also the hemodynamic effect of the ventricular septal defect. Next slide. For the management, if the ventricular septal defect is small and it usually closes spontaneously and the surgical intervention is not needed. If it does not close, we need to do the surgery. And the surgical closure is also indicated in the aortic valve prolapse to prevent the progression of the aortic regurgitation. For the moderate and large ventricular septal defect, because the patient have the sign of the heart failure and also the sign of the lung congestive syndrome, we need to give the diuretic to reduce the lung congestive symptoms. And surgical ventricular septal defect closure is indicated if the heart failure symptoms remain severe despite the optimal medical therapy. These are our references. I think that's all from us.
Okay, thank you. Go to the first slide. Any questions on the VHD? Okay, I think next slide. I think this one you can read. Okay, the type also. Okay, the type is based on the location. In terms of hemodynamics, pathophysiology is almost similar. Okay. Okay. The importance probably to the surgeons or to the cardiologists when we plan to close the defect. Okay, next. Okay, so this part, thank you, important part to, okay. So the small VSD dengan large VSD. Okay. Oh, dia nak ni. It's okay. Okay. This is the characteristic of VSD. Special for VSD. Like ASD just now, it's the fixed, white fixed 15-second heart sound. Okay. For VSD, the small VSD, the louder the murmur. Okay, loud murmur in small VSD. So clinically, if you can heard the loud murmur, grade 4 or 5 over 6, it's suggestive of the small VSD. It's not necessarily true, but in general, it's that the character of the VSD. The other cardiac lesions, the larger the lesions, the louder the murmur. Okay, but in VSD is opposite. Okay, and this the signs mainly the heart failure symptoms, sign and symptom heart failure. But this one, I think it's not that accurate. Okay, the heart failure is not commonly occur earlier. It's not common occur in first week of life. It's usually at the 6 to 8 weeks. After 6 to 8 weeks, and then the symptoms develop. Why? That's the time when your pulmonary pressure is normalized. Because pulmonary pressure takes time to normalize. It takes 6 to 8 weeks to normalize. This is the time when the PA pressure at the lowest is normal. So that's the time the maximum optimum shunting happen. Prior to that, at birth, the PA pressure is quite high. Okay, so there is no significant shunting occur, even though you can see left to right shunt, but it's not much until the PA pressure coming down. Then the shunting left to right shunt occur at the maximum, and then the time when the patient start to have sign and symptom of heart failure. Tachypnea, tachycardic, clinically patient become shortness of breath, interrupted feeding, failure to thrive, sweating during feeding. So all the symptoms of heart failure. Okay. The next slide. Okay. So this if untreated, patient develop as a manga. It's usually if large VSD is developed earlier, okay. Heart failure is earlier, around 6 weeks to 8 weeks, at 2 months old. But in few years time, if you not treat the VSD, patient can develop as a manga, large VSD. Okay. That this the like ASD is the end stage when the reversal of the shunt. End stage is irreversible and inoperable. You cannot do anything already. Okay. So next slide. Okay, this one I think you can, the chest X-ray, you can see the cardiomegaly. Chest X-ray is very helpful in deciding whether the significant shunting or not. Significant volume overload or not. Okay, because if there is no significant volume overload, there is no cardiomegaly, and there is small VSD. There is cardiomegaly, we know that there is significant left to right shunt, volume overload. Okay, next. Any questions on VSD from the members and or from the presenter group? Any questions? Okay, who's presenting just now? One question.
Me, doctor.
Presenting? Wei Hua. Wei.
Yeah.
So which chamber will be dilated in VSD? Left side or right side chamber? Left ventricle or right ventricle?
The right ventricle.
Sorry, which?
The right ventricle.
Okay, so if you go use the common sense should be right ventricle because left to right shunt, but it's wrong.
Oh.
Okay, In ASD, yes. That's why I say sometimes common sense without knowledge, we can be wrong. Okay. Okay, let me share my screen. Can you stop sharing? In ASD, yes. ASD is right ventricle dilated, but not in VSD. Okay. I don't know. Okay. In VSD, okay, when was the shunting? When the shunting occur? During systolic or during diastolic?
The shunting during systolic.
During systolic. Okay. So what happened to the right ventricle during systolic? What happened to the right ventricle during systolic?
It would contract as well.
Contract lah, ya kan? It's almost contract at the same time. So you see here, okay? When it's contracting, there is shunting. So at the same time, when the blood go to the right ventricle already contracting. So all the blood is shunting to the right side, is pushed into the pulmonary artery. So the blood is not stay in the right ventricle. Okay, the blood push immediately to the pulmonary artery to go to the lung, come back to the left atrium through the pulmonary vein. So left side of the heart receive increased blood volume. It's not right side. So it's the overload to the left side. It's similar with PDA, but PDA much easier to understand. Afterward, they're going to present PDA. Because PDA from descending aorta into pulmonary artery straight away. It's not going to the right ventricle at all. Okay. So dia akan overload to the left side. So LA-LV going to be dilated in moderate to large VSD. It's different from ASD. In ASD, left to right shunt, left atrium. During diastolic, all the volume from the right atrium can stay in the right ventricle. So the all volume. So that's why the right ventricle is dilated, but not in VSD. The right ventricle will be dilated in VSD only when patient develop severe pulmonary hypertension, meaning that develop complication already, then the RV dilate. It's not because VSD, it's because pulmonary hypertension. Even patient without ASD or VSD with pulmonary hypertension also will right ventricle will be dilated because high pressure on the pulmonary artery. So right ventricle need to harder to push the blood into the pulmonary artery, so it will hypertrophy and dilated. Okay, so that's the physiology you need to understand. Okay, it's not the right ventricle. Okay, so I think go to the next. Any questions? If not, we go to the second last presenter on PDA.
Okay, Doctor.
Okay.
Okay, so we will proceed with Titan Doctor's arteriosus. Okay, what is ductus arteriosus? So, ductus arteriosus is a fetal vessel that connect the pulmonary trunk to the descending aorta. So, this allow the mixed blood from the right ventricle to perfuse to the caudal part of the fetal. And after birth, usually after 2 to 3 days, it will be closed due to the contraction of its muscular wall and forming the ligamentum arteriosum. So in patent ductus arteriosus, the ductus arteriosus did not close and failed to obliterate in around like afterwards around like 72 hours. So usually the ductus arteriosus will close because of the presence of the bradykinin and then increase in oxygen tension when the lung expand when the baby cry, and then destruction of the ductus arteriosus endothelium where the endothelium will migrate to the subendothelium and then creating mound and later obliterate the PDA lah. But kejap. So when in the PDA, in the patent ductus arteriosus, there will be less bradykinin released by the lung, and the wall of the ductus arteriosus will produce vasodilators continuously, such as the prostaglandin and the nitric oxide. So when this happened, the ductus arteriosus did not close. So as the pressure in the aorta is higher than the pulmonary artery, this will cause the aortic blood will shunted into the pulmonary artery through the open ductus arteriosus just now. So this will cause a lot of large volume of blood to go into the lung and cause the high pressure in the lung, which is the pulmonary hypertension. And it will later cause the congestive heart failure because of the increase in the heart they need to work harder to pump blood into the lung. So for the sign and symptom of the PDA, it depends on the amount of the pulmonary blood flow and depend on the size of PDA and also the pulmonary vascular resistance. So for the symptom of the PDA, usually if it's small, it is asymptomatic. But in large PDA, we might have the symptom of the heart failure, such as the shortness of breath, failure to drive, and also fatigue. And the signs that we can look for is the collapsing bounding pulse, which is due to the increase of the pulse pressure and due to the runoff of the blood into the pulmonary circulation during the diastole. And then we can also palpate the hyperdynamic precordium is when we palpate the apex. We can feel the impulse has increased in the amplitude and there will be more than one intercostal space, the impulse. And then we can also hear mid-diastolic murmur at the apex due to the increase of the flow across the mitral valve. And then we can also feel for the trill beneath the left clavicle, and we can hear a loud pulmonary valve closure and continuous murmur beneath the left clavicle, and it will radiate along the pulmonary arteries and also often we'll hear over the left side of the back. So for the investigation of the PDA, we can do chest X-ray. So in the large PDA, we can see a prominent pulmonary artery with increase of the pulmonary vascular marking. And the cardiac side depends on the degree of the shunting. So it might be normal or moderately enlarged. And the aortic knob may be normal or prominent. For the ECG, usually in the small PDA, it will be normal. But we might detect some left ventricular hypertrophy or biventricular in large PDA, where there will be increase in the R wave amplitude in the left ECG lead and also increase in the S wave in the right ECG lead. And then we can also do the echocardiogram, which is if the ductus is small, we can see a normal cardiac chamber dimension, but if in a large shunt, the left atria and the left ventricular may be increased in dimension. And the ductus can be visualized directly and estimated its size, and use of the Doppler in systolic or diastolic or both in the pulmonary artery can be seen in the Doppler, in the echocardiogram. And then for the management, in most preterm infant, the duct will ultimately close. But if it's symptomatic, we will proceed with the treatment of fluid restriction and diuretics, endomethacin, or surgical ligation may be required. So in a small PDA, there will be no treatment if there are no murmur. But if murmur are present, we might do the elective closure as a risk of endocarditis. There are risks of the endocarditis because of the high velocity at the PDA. It can cause the blood it can cause the sticking of the blood clotting, and then it can increase the risk of endocarditis. And then for the management of the moderate to large PDA, we can give the heart failure drugs, for example, like the diuretics, beta blockers, ACE inhibitors, and the timing of the method of the closure. We may do the surgical ligation or the transcatheter closure, depend on the symptom and the severity, the size of PDA, and also the body weight. And for the prognosis and the complication, small PDA may live a normal span with few or no cardiac symptom. But in the large PDA, the cardiac failure in early infancy, there might be a cardiac failure in early infancy, but it also may occur later in life. And like I said before, it has a high risk in the infective endocarditis. And the rare complication is the aneurysmal dilation of the pulmonary artery or the ductus, calcification of the ductus, non-infective thrombosis of the ductus with embolization, and paradoxical emboli. And also, we might have the pulmonary hypertension, which is the Eisenmenger syndrome in patients that do not undergo the ductal closure. That's all for our group.
Go to the first slide.
Okay.
Any questions? I think quite straightforward, isn't it? Yeah, so who asking? Amirul, yes, Amirul. No need. Because you determine the size by echocardiography. We not need to do. You do not need to know how to do echocardiography, but you need to know clinically whether the PDA large or small. Okay, clinically you need to know. So based on clinical failure symptom, patient ada failure symptom, first heart murmur, is loud or not loud. Second, patient there is any failure symptoms, any chamber dilatations or not, cardiomegaly or not, clinically from examination before you see the chest X-ray. And there is peripheral signs of PDA like your friend mentioned just now. Bounding pulse. Usually bounding pulse is not collapsing pulse, it's bounding pulse. But there is some people who consider bounding and collapsing pulse is the same thing. But to me, bounding pulse is not necessarily collapsing pulse. Collapsing pulse must be bounding. Okay. And the white pulse pressure, I think you not mentioned just now, white pulse pressure. That's the peripheral signs of PDA, white pulse pressure. But you mentioned the increased pulse pressure, probably the same thing. Okay? You do the BP, how you, Adelina, you're presenting, how you know is whether white pulse pressure or not?
I'm not sure.
Okay, anybody tahu? I think in PICS, I'm not sure in PICS protocol they mentioned or not. There is calculation to know that one, but in general, it's depend on the age of the patient. But in general, white pulse pressure is you say it's white pulse pressure when the diastolic BP is less than 50% of systolic. Like say the systolic is 120, so if diastolic less than 60 millimeter mercury, it's considered white pulse pressure already. So it's indicate suggestive of large PDA. Is the BP systolic 80, mean the diastolic less than 40 millimeter mercury is considered white pulse pressure already. Okay, so white pulse pressure, bounding pulse, loud, continuous murmur, cardiomegaly, so it's suggestive of large PDA. You are not needed to know how to measure the size. It's okay. It's not you don't need to do that. But to appreciate the signs and symptoms, yes. So from that, then you can decide whether it's large PDA or small PDA. Okay, next. Next. Okay, this one again. Next. Next. I think I went to the outline of management. Next. Okay, this one. Okay. So this one, the in preterm. Something sikit. Can you allow me to annotate it? Okay, in preterm treatment. Okay, indomethacin. This is the anti-failure. If patient failure similar with the bigger patient, but indomethacin, NSAID. And now the latest one is paracetamol. Medication to close PDA only applicable for preterm baby. There is no role of this medication for term baby. In term baby, if not closed, we need to close surgically or by device closure. Surgical ligation is by surgical, or we can use the device like ASD, VSD device to do transcatheter closure. We can do that. Okay, that's the important thing. Maksudnya there's no role of indomethacin, brufen or paracetamol to close PDA in term baby. This only applicable for term preterm baby, because the mechanism of PDA in preterm is different from term baby. In preterm is because of the immaturity of the receptors. So dia tak boleh nak respond to the bradykinin and so on. So dia tak close, nak delay closure. So that's the point I want to emphasize. Any other questions before we go to the last presenter? Okay, kalau tak ada, go to the last presenter on TOF. Who's presenting?
Me, doctor. Wait, I want to share this.
Okay.
Oh my God. Hello and Assalamualaikum. Can you guys all hear me?
Yes.
Yes.
Okay. So now I will start presenting about tetralogy of Fallot. So this is our outline. I will start with the definition. Okay. What is meant by TOF is it is the most common cyanotic congenital heart disease. Is for the percentage by Nelson, it's stated 10%, but some of the books stated 5%. So what you need to know, I think, is just the most common. And there are 4 structural defects that you need to know in TOF. The first one is narrowing of the right ventricular outflow. So there will be pulmonary stenosis. And next will be ventricular septal defect and overriding aorta. And the last one is right ventricular hypertrophy. This happened due to abnormal septation of the truncus arteriosus into the aorta and pulmonary artery that occurs early in gestation, usually between 3 to 4 weeks. Okay, why this happen? Usually there are many causes, like I will explain later in the petaphysio. So from this statement, abnormal septation of the truncus arteriosus, is there something that you might be confused with this statement? Anyone want to try? Okay, never mind. So as for me, I might be a little bit confused. What is truncus arteriosus and ductus arteriosus? So I want to ask you guys, is it the same, truncus and ductus arteriosus? Anyone want to try? Or I will pick up any name. Okay, Adina, do you think is it the same, truncus and ductus arteriosus?
I think no.
Yes, it's no, because ductus arteriosus is a fetal vessel that connect pulmonary trunk and descending aorta. But truncus arteriosus, what we learn in development, is the heart tube that will be divided into three things from the bulbous chordae. So this truncus arteriosus later will develop into pulmonary trunk and ascending aorta. So ductus and truncus arteriosus is not the same thing. So everybody clear about that? Okay, next. Why cannot? Okay. Okay, for the clinical features of tetralogy of Fallot, for the symptoms, usually it will be diagnosed antenatally following the identification of a murmur in the first 2 months of life. So usually it will be presented with cyanosis, hyperpnea. Hyperpnea occurs because of the gradually increasing cyanosis and also the loss of murmur, so resulting in hyperpnea. Hypercyanotic spells, irritability, and restlessness. For the signs, the baby will present with clubbing of the fingers and toes. This one is for older children, so it will present with clubbing of the fingers. And a loud harsh ejection, systolic murmur at the left sternal edge from day 1 of life. Doctor, before that, I want to ask something. Is it hypercyanotic spells is the same thing as hypoxic spells?
Hypercyanotic spell and hypoxic spell. Yeah, I think it's same thing.
Okay, thank you,
There is
Doctor.
few terminology for that. Hypercyanotic spell, hypoxic spell, the TET spell.
Okay. Thank you, Doctor. So there you might use hypercyanotic spells, TET spells, and hypoxic spells is the same thing. It's just different on different groups. Sorry, Doctor, can you unmute yourself? Okay, thank you, Doctor. Okay, for the pathophysiology, okay, this one, as I mentioned just now, there are variety of causes why it will be affect the gestation period. It will be cause abnormal because of the genes defect, microdeletions, trisomies, because of the maternal exposure to alcohol, and etc. So for the pathophysiology, so this is a bit complicated. I will just explain verbally. So as you know, when the child have TOF, it have pulmonary stenosis. So when it has a pulmonary stenosis, it will cause increased resistance for the right ventricular outflow. So increased resistance. So that's why the right ventricle need to contract harder to overcome the resistance. That's why it will become right ventricle hypertrophy. So, and also due to the transposition of the aorta and ventricular septal defect, the deoxygenated blood from the right ventricle will be shunted to the aorta. So it will cause a right to left shunt. So since it will be shunted in the aorta, the deoxygenated blood from the right ventricle will mix with the oxygenated blood from the left ventricle.
Can you use the pointer so your
Okay.
friend can appreciate better your explanations?
Sorry, Doctor, just now I this is a bit complicated. So my I just what I explain is just verbally, because this one is more to pathophysiology of signs and symptoms. Okay. So since the aorta, the oxygenated blood and the oxygenated blood mix, so it will cause the mixing of the blood. That's why the mixing will cause the cyanosis to the baby. Okay. So later on you will read yourself about this further explanation about what it lead to signs and symptoms. Okay. For the complications, TOF will result in hypercyanotic spells. Okay, for the child diagnosed with TOF, you need to Adelina, unmute yourself. Okay. For that's why we need to recognize early about hypercyanotic spells, because later on, it will lead to myocardial infarction, prolonged unconsciousness, convulsions, hemiparesis, cerebral thromboembolism, cerebral abscess, and also if left untreated for a longer time, it will lead to death. That's why once a patient that presented with hypercyanotic spells, it is important to take further management. Okay. What is hypercyanotic spells? Again, it's the same as hypoxic spell and also TAC spell. Okay, it means it is sudden severe episodes of intense cyanosis caused by reduction of pulmonary flow in patients with TOF or other cyanotic heart lesions. Okay, what is the clinical presentation of it? The peak incident will be 3 to 6 months. Often it will occur in the morning and will be worsened by if the baby crying, feeding, and also defecation. Okay, it will cause a severe cyanosis, hyperpnea, metabolic acidosis. In severe cases, it may lead to syncope, seizure, stroke, or death. Okay, it will reduce intensity of systolic murmur during spell. Indeed, for the patient who have hypocyanotic spells, when doing a physical examination on auscultation, there is a very short murmur during a spell. Sometimes it's very short murmur that you can hear. Okay. Go next. Okay. Next, for the management, the practitioner need to treat the condition as a medical emergency. Put the child in knee, chest, or squatting position, or as shown in the picture. Place the baby on mother's shoulder with knees tucked up underneath. So this will increase systemic vascular resistance so that the blood will less blood will shunt from right ventricle into aorta. So it will less mix lah. And then we'll administer 100% oxygen because this child have cyanosis. Give either intravehicular, intramuscular, or sorry, I forgot. Acetaminophen 0.1 to 0.2 milligram per kilogram to reduce distress and hyperpnea. Okay, if the measures mentioned before fails, can give intravenous propranolol. Propranolol is a beta blocker. Okay, from 0.05. I think, Dr. Is it we need to remember all the dosage?
Don't worry about the dosage.
Okay. So what you need to know, you can give intravenous propranolol. Alternatively, can use IV esmolol. I can IV infusion also. And also, esmolol is an ultra short-acting beta blocker. And also can give a crystalloid or colloid to increase preload. Give IV sodium bicarbonate to correct metabolic acidosis. And also can give heavy sedation, intubation, and mechanical ventilation. But if still they're in resistant cases, it's important to consider IV phenylephrine, noradrenaline infusion. This can to increase systemic vascular resistance and reduce right and left shunt. And also emergency blood lock tosing shunt. This one is a surgical procedure. As you can see in the picture, you can see this one is a modified. This is blood lock tosing shunt. This is just a small tube that connects the arterial circulation to the pulmonary circulation in order to get more blood to the lungs to ensure that baby get oxygen well. So important in a single episode of hypercyanotic spell. That's why we need to recognize early when the patient have hypercyanotic spell because it can lead to various complications. And also oral propranolol 0.2 to 1 milligram per kilogram per dosage 8 to 12 hourly should be started after stabilization while waiting for surgical intervention. I think that's all from me.
Okay, any questions? Go to the first slide. Any questions? Semua faham? Okay, so I think quite anatomically it's quite straightforward. Tetralogy of follow. The name itself tetra is 4, so 4 abnormality mentioned by your friends. But I think the importance probably to understand is the pulmonary stenosis. Okay, the pulmonary stenosis. Yeah. So it's mainly involve the what we call the infundibulum area, infravalvular, subvalvular area. Yeah, they can involve the valvular and subvalvular. So this area is the muscular area. So it can be it's dynamic. It can become contract and relax. But it may involve both. But the main component is infundibulum in the POF. But some baby they may involve both the infundibulum and valvular. The valve also small. Okay, so next. Next slide.
Sorry, Doctor, I can't click.
You can. It's okay. You stop your sharing. It's okay.
Where do I stop? Wait, Doctor.
So you mentioned just now about the hypersonic spell. We go to the hypersonic spell.
Okay.
Okay. Yeah. So the keyword here is the sudden. Okay. The sudden severe episode of intense cyanosis. Patient already cyanosis, it's cyanotic, congenital heart disease. It's sudden worsening of cyanosis. So it's the hypersensitive spell. Okay, so this is the triggering factors. And you mentioned just now the mechanism is because of the infundibulum stenosis, isn't it?
Yes.
Yeah. Any other mechanism? You mentioned one of the mechanism just now.
I'm not sure about the other mechanism.
You're not sure, but in your management, you did mention that actually. That the mechanism is regards to systemic vascular resistance, reduce systemic vascular resistance. When we talk about systemic vascular resistance, what do you mean by systemic vascular resistance, Anis? For other people, what do you understand about systemic vascular resistance? Okay, you selalu sebut ni. What your understanding? It's relate to what? When we talk about the systemic vascular resistance, it's relate to what?
Doctor, it is related to the pressure inside the left ventricular.
No. It's not accurate. Sorry? Relate, but what cause the blood pressure? What? Cardiac output and? So peripheral vascular resistance relate to what you mean by peripheral vascular resistance?
Doctor, is it
Peripheral vascular.
blood flow?
Yelah, memanglah resistance of what? Apa dia tu?
Is it the arterioles, Doctor? Resistance imposed by the arterioles.
What happened to the arteriole?
If it's vasoconstricted, then increase the resistance.
Yes. When you talk about the systemic vascular resistance, you refer to the vasoconstriction and vasodilation. Vasoconstriction causing the increased vascular resistance or increased peripheral resistance. Vasodilation reduce systemic vascular resistance. BP increase when increased systemic vascular resistance, that is vasoconstriction. But the antihypertensive, most of the hypertensive cause vasodilation to reduce the BP. So in hypersonic spell, why I highlighted that? Because in hypersonic spell, there is two mechanisms. One is what your friend mentioned just now. Okay, your friend mentioned about the infundibulum stenosis. Yes, like I mentioned, because infundibulum is the dynamic. You boleh spasm. Okay. And satu lagi is sekarang dia ada VSD macam ni. Dia ada hole. So overriding of iota kat sini. Okay. Alamak. It's okay. And satu lagi pulmonary artery. Pulmonary artery ni dia ada pulmonary artery, dia ada infundibulum stenosis kat sini. Okay. So when there is spasm here, what happen? Blood cannot go to the lung. Blood cannot go to the lung, so dia akan go to the left side. More increased right to left shunt. That's causing worsening of stenosis. So it's two mechanisms. One because of the spasm. So when they can, because the principle is the fluid principle, dia akan flow from high gradient to low gradient. So kalau kat sini high gradient, dia tak boleh pergi, dia akan go to the left side. The other condition on the left side is the systemic vascular resistance, reduced systemic vascular resistance, or in other words, vasodilation. Walaupun katakan infundibulum not spasm, so suddenly there is reduced systemic vascular resistance. So now the resistance on the left side reduced, so more blood go to the left side. Okay, so more deoxygenated blood, blue blood go to the left side, so patient become worsen stenosis. So what condition can cause reduced systemic vascular resistance?
Exercise.
Exercise, hot bath, okay. This anything yang cause vasodilatation. So patient akan become worsening of stenosis. Okay. So if it happen, the two mechanism occurs concurrently, the stenosis become more severe. Okay. That's why one of the treatment is knee chest position or squatting. You increase the systemic vascular resistance. So when the increase systemic vascular resistance here, so blood must have difficulty go to the left side. So more blood push to the lung. So that's the. So can we go to the slide of the management?
Okay. Wait, doctor. I can't. Okay.
Okay. Can you see here the slide of management? Okay. Knee chest or squatting is to increase systemic vascular resistance. Okay, it may help. Morphine, SC is subcutaneous. Subcutaneous morphine, IVR, anything lah. Morphine is to calm the baby, so reduce the stress, because stress can trigger the spasm of the infundibulum. So calm the baby. Next slide.
Wait, doctor.
Okay. And propranolol is beta blocker, esmolol is beta blocker, is actually to reduce the spasm, to relax the muscle of the infundibulum. Okay, so that's there. So and then volume, you give fluid is to increase the preload. So hoping that more fluid, more volume, more blood push to the lung. Okay, because dehydration can trigger the hypertensive spell. Sodium bicarb is to overcome the complications of the hypoxia. Patient akan become metabolic acidosis to correct the metabolic acidosis. You give sedation, intubation if the resistant cases, so very difficult to control, so you give the sedation or you intubate the patient. So you have better control on the patient. Okay, so the next slide. Okay, so the next slide, you give phenylephrine. What is phenylephrine? Anybody know?
Decongestant.
No.
Beta vasoconstrictor.
That one is the decongestant is different. That's pseudoephedrine. Phenylephrine is the potent vascular vasoconstriction. So you want to cause the vasoconstriction, peripheral vasoconstriction, to increase systemic vascular resistance. So, and hoping that to reduce right to left shunt, so reduce the cyanosis. Okay, so if you understand the mechanism, so you will explain why we give. Don't worry about the dosage. The principle, important to understand the principle. Don't worry about the dosage. No need to memorize the dosage yet. Okay. So the other option is doing if the recurrent or difficult to control is emergency BT shunt, Blalock Tastic shunt. This one modified, like you mentioned, is modified. We put the small tube from the branch of the aorta subclavian artery into the pulmonary artery. So you increase blood flow, oxygenated blood flow to the lungs, so you improve the saturation. Okay. Why we say modified? Because the classic BT shunt, when they first invent this procedure, they connect directly, the subclavian directly connected into the pulmonary artery. But the problem, you compromise the blood flow to the artery. Because you cut here, you cut the subclavian and connect to the pulmonary artery. But later they modify, so they put this small tube, synthetic tube, so increase the blood flow to the lung, at the same time maintain the blood flow to the spleen. Any questions? Okay, for your level, I think for the undergraduate level, don't worry about the dosage. It's important to understand the principle and try to know what the medication is. Like phenylephrine, what is phenylephrine? You don't need to know anti-molecular level. You know that its potent vasoconstriction is good enough already. Okay, so you understand why we give. What is propranolol, beta blocker, so act. What is the actions of this beta blocker, for example? Any questions? So Jana, I need your help. Can you every group, can you submit the slide to Jana? You compile the slide and you WhatsApp or email to me. You can email to me in PDF form. It's just as evidence that we have these sessions. I need to keep that. That's all from me. If you have question, because we're going to meet face to face, hopefully in few weeks time, kan? I don't know. I don't think we will come next week. In 2 weeks time. KPM. Sorry. Yes.
Question. The trilogy of failure.
Siapa yang tanya ni? Siapa tanya ni?
Wan Ainul Basirah.
Kuat sikit.
Okay, I want to ask because patient with TOF, they have the ventral septal defect. Is the murmur of ventral septal defect prominent in TOF?
Tu soalan you, is prominent or not?
Yeah.
That's a good question. Yeah. Good question. First I ask the presenter and the team lah. What do you think? First, I want to ask the presenter of VSD just now, group number 4, isn't it? How the VSD pansystolic murmur of VSD develop? Can happen. How? Because you understand this, then you can answer Basirah question. Who's from group 4? VSD group just now? How?
Me, doctor.
Yes.
The pansystolic murmur occur at the onset of the systole.
Yeah, that's why we call pansystolic murmur. But how the murmur develop? It's because of what? Like ASD, because of turbulence flow across the pulmonary valve. But in VSD?
The turbulent flow across the opening.
Okay, what caused the turbulent flow? What caused the turbulent flow in VSD?
During the systole, the left ventricle greater than the right ventricle.
The pressure gradient, the difference of pressure between left ventricle and right ventricle. So there is pressure gradient between left ventricle and right ventricle. Okay. So it causes the turbulent flow across the VSD. The smaller the VSD, the more turbulent flow. Dia macam pipe air. You tekan tu dia pancut lagi. Tahu. Okay. So there akan more turbulence in small VSD. Okay. But in TOF, okay, so the keyword here is the pressure gradient, the gradient difference. In keyword in TOF, can you back to the first slide gambar TOF tak? Okay. So in TOF, okay, this is the VSD. Okay. But you must remember that in TOF the RV pressure is high because of the pulmonary stenosis. There is obstruction here. Obstruction at the pulmonary level, pulmonary valve level. So the RV pressure is high. Because of that, that's why the right to left shunt, beside the overriding, the RV pressure is high gradient. So it contribute to right to left shunt. So basically in terms of pressure, there is not much difference pressure between LV and RV. It's almost similar. So almost there is no pressure gradient between RV and LV. So the murmur of the TOF is, what is the murmur of TOF? Who's presenting TOF just now? Anis kan?
Hush systolic ejection.
Ejection systolic murmur. Ejection systolic murmur, okay? So the murmur of TOF is the pulmonary stenosis murmur, ejection systolic murmur, okay? It's not because of VSD. If you have device to close, to mask the ejection systolic murmur, you still cannot listen to pansystolic murmur. There won't be pansystolic murmur. Probably they got some soft systolic murmur because of the flow here, but won't be loud pansystolic murmur because there is no significant gradient between RV and LV. The murmur is mainly because of this narrowing of the infundibulum and pulmonary valve causing ejection systolic murmur. Is it answering your question, Basira?
Thank you.
Okay. Any other questions before we end? Okay, if not, okay. So if you have any question, you can keep your question, or you can WhatsApp me. But because we're going to have, hopefully we're going to have face-to-face session soon. So you can keep, and when you come back, you can ask that question. But if you cannot wait, but I think you won't come in near lah. Probably the earliest in early March. So probably they're going to extend the online teaching. Looking at the current scenario, in fact, I think the KPM, Kementerian Pengajian Tinggi, also already, give the instruction the student only come back in 1st March, I think, but not all students. So I don't know what is their plan. But I don't think you will come in after Chinese New Year. Okay, but if you have any question, you can WhatsApp or email to me. I have time, I will answer. Okay, if no further question, thank you very much. Hope that you benefit from the session. But then definitely you can go through back. Okay, try to understand the physiology, pathophysiology behind. Because then you understand the management, why we do certain things in certain conditions. Yeah.
Doktor, nak tanya sikit.
Yes. Siapa ni?
Ruzaini.
Ruzaini. Yes,
Nak
Ruzaini.
tahu ASD dengan VSD mana lagi common?
VSD ya. Maksudnya secara ni VSD is the most common. VSD is the most common congenital heart disease, followed by ASD. TOF is the most common cyanotic congenital heart disease.
Thank you, Doctor.
Okay, okay. Okay, kalau tak ada apa-apa, we end here. Okay, stay safe, take care. See you soon, hopefully.
Thank you, Doctor.
Okay,
Doctor.